Ladies and gentlemen, welcome to the final plenary for the day. My name is Stephen Clark. I'm the Chair of the ISQua Accreditation Council. It gives me great pleasure to announce the awards for the last 12 months for the International Accreditation Program. ISQua has awarded 172 sets of standards, 36 surveyor training programs, and 84 organisations. Since its existence in 1999, in the last year, we have accredited a further 10 organisations, 10 sets of standards and 4 surveyor training programs. In total, we have carried out 292 surveys since 1999. I think that's a great effort. I'm going to call out the organisations now that have achieved their award. And when I do, would you please stand up where you are in your seat? It's a little bit hard to see from here, so if I don't see you, shout out, wave your hand, do whatever you do to get my attention so I can recognise you. And we now have a very large international reach going from Argentina to the United States, so a huge reach for ISQUa's International Accreditation Program. These organisations have achieved accreditation since September 2017 to August 2018, and they were assessed against the ISQua guidelines and standards for external evaluation organisations, the 4th edition. To start us off, the Australian Aged Care Quality Agency accredits Australian government subsidised aged care homes and conducts quality reviews of home care and Aboriginal and Torres Strait Islander flexible care services. The agency also provides compliance monitoring, information and training to providers and works with the community to promote quality care for older Australians. We have people in the... Thank you very much and congratulations. Well done. Established in 1997 by industry members, AGPAL is a leading not-for-profit organisation providing general practice accreditation and quality improvement services within Australia. AGPAL is committed to servicing and supporting GPs, medical deputising services, after-hours services, Aboriginal medical services and Royal Flying Doctor services throughout their accreditation journey. We have 2 gentlemen in the audience, I think Richard Chung and Gary Smith. Now these are actually, before you clap hands, these are actually my employers, my boss. So I'd like you to wave to them. Just give them a big wave, all of you. It's fantastic. Thank you very much. The Japan Council for Quality Healthcare is a neutral third-party organisation in healthcare established in 1995 in Japan. JQ aims to contribute to the improvement of the health and welfare of the people by improving healthcare quality and ensuring a trustworthy healthcare system. You're beating me to it, people. Well done, Japan. Founded in 1944, the Brazilian Society of Clinical Pathology Laboratory Medicine aims to join together professionals to continuously improve the health of the community. They were first organisational survey since 2015. Are they present in the audience? Okay. The American Accreditation Commission International develops person-centred standards for healthcare services to improve the safety, well-being and quality of life and quality of care throughout the world. This is their first organisational survey. Are they here at all? Yes, thank you. The Australian Council on Healthcare Standards is an authorised accreditation agency with the Australian Commission on Safety and Quality in Healthcare. The ACHS is authorised to accredit healthcare organisations to the National Safety and Quality Health Service standards, and these standards form the basis of many of their accreditation programs. This was the organisation's 5th organisational survey, and they're here in good numbers. ACHS, well done. The Canadian Accreditation Council of Human Services is dedicated to promoting service excellence by using a peer review process based on best practice standards. The CAC believe in the process of accreditation and have chosen to make themselves accountable to international standards with a focus on continued improvement. Are they here at all in the audience? Okay. Building on more than 150 years of expertise in working with high-risk industries to make them safer, DMV work with healthcare providers, national and regional health authorities and key stakeholders around the world to improve healthcare quality and facilitate the provision of patient-centred, safe care. This was their second survey. Are they here at all in the audience? The Healthcare Accreditation Council in Jordan is a private, not-for-profit, shareholding company registered with the Jordanian Ministry of Industry and Trade since 2007. It aims to promote quality improvement and patient safety through accreditation, capacity building and consulting across Jordan. Is HCAC here at all? Yes. The following organisations who have a set of their standards accredited between September 17 and August 18, I'm going to read now. So this is standards accreditation. The ACSA aims to enhance the quality of services provided by organisations and healthcare social service professionals. The challenge is addressed by promoting the so-called Andalusian quality model, always pursuing excellence in healthcare and social welfare and fostering a culture of continuous improvement. Are they here at all? Congratulations, thank you very much. The Egyptian Healthcare Accreditation Organisation had their hospital standards ISQua accredited for the second time. Are they here at all? Yes? Well done, thank you. The Joint Commission International works to improve patient safety and quality of healthcare in the international community by offering education, publications, advisory services and international accreditation. This year they had their 6th edition hospital standards accredited by ISQua. JCI? Paul? Well done. The Healthcare Accreditation Institute was initiated under the Health Systems Research Institute as a research program in 1997. Since this time, HIA's clients include more than 1,000 public and private hospitals in Thailand. And they are here, I'm sure, in the audience? Yes? The Department of Productivity, Quality and Accreditation in Health is committed to providing patient and employee safety and satisfaction in all Turkish health services in an effective, timely and equitable manner. Is there anyone here from Turkey? Yes. ONA was founded in 1999 by public and private health sector entities. Its creation is linked to the changes that occurred after the 1988 Constitution, which defined health as a right of every citizen. And ONA, you are here, I think? Yes? The Organisation of European Cancer Institutes is a non-governmental, not-for-profit legal entity established in 1979 to promote greater cooperation among European cancer centres and institutes. Are they here at all in the audience? AXA had a very busy year, also achieving accreditation of their Clinical Management Unit Manual. Are they here at all? Here come the boys again. AGPEL has had their QIC Health and Community Standards accredited in 2018. And Gary and Richard, congratulations. The Romanian National Authority of Quality Management in Healthcare is a government organisation with responsibility for the evaluation and accreditation of health services in Romania. Their hospital standards were accredited for the first time this year, and they are here, I'm sure. Okay. The College of Physicians and Surgeons of Alberta is a regulatory and representative body supported by physicians in Alberta. Their diagnostic laboratory standards were accredited for the second time this year. In 2018, JCI also achieved ISQua accreditation for their primary care standards. Once again, JCI, well done. The Japan Council for Quality Healthcare has also had their hospital standards accredited in 2018. Congratulations. This will be big. The Joint Commission of Taiwan is an independent, not-for-profit organisation established in 1999. They are committed to promoting quality and patient safety concepts, the use of quality management tools and healthcare professional training. This is the first time that their standards have been accredited. Park Chun, you're here. Congratulations. INIS is an independent public authority in Tunisia working in the fields of health product evaluation, professional practices, organisation of care and public health. This year they received accreditation for their primary healthcare standards for the first time. Well done. The Laboratory Medicine Foundation was established in 2010 by the Korean Ministry of Health and Welfare. This is the first time that the standards for their laboratory medicine accreditation program has been accredited. Are they here at all? Yes, well done. The following organisations have achieved Surveyor Training Program accreditation. The Joint Commission of Taiwan had a very busy year, also having their surveyor training accredited by ISQua. This is the second time their surveyor training program has been accredited. Well done. Congratulations. You have to stand up again, fellows. AGPEL has had their surveyor training programs accredited for the first time in 2018. Richard Chung and Gary Smith. I should get a raise. It's 3 times. The Saudi Central Board for Accreditation of Healthcare Institutions is the official agency authorised to grant accreditation certificates to all government and private healthcare facilities operating today in Saudi Arabia. Their surveyor training program was accredited for the first time this year. Are they here at all? Yes? Congratulations. Established in 2006, the National Health Systems Resource Centre, a mandate is to assist in policy and strategy development in the provision and mobilisation of technical assistance to the states and in capacity building for the Ministry of Health. Their surveyor training program was accredited for the first time this year. Are they here at all? The ISQua accreditation program and ISQua in general would like to recognise the contributions of Tan Sri City to improving quality and safety in Malaysia during her leadership of MSQH. Tan Sri City has also created many significant milestones and achievements to support quality improvement and ISQua accreditation in healthcare at national and international level by creating a formal network of healthcare-related organisations in the Asian regions. Please give her a special applause. And that concludes the awards, ladies and gentlemen. Thank you very much.
Good afternoon. This is not in your program at this time. However, I'm pleased to be speaking about Dr. Renee Amrabetti, who many of you know. Tomorrow morning is to be the time to give Distinguished Service and Lifetime Achievement Awards. However, Renee needs to fly back to France in a few hours. So I've taken a chunk out of tomorrow morning for a few minutes, and it's my pleasure for us to recognize Renee for the Distinguished Service Award. So let me just tell you a bit about Renee. Renee is a professor of medicine, physiology, and ergonomics. He currently works part-time as a senior advisor to the Haute Autorité de Santé in France. After a residency in psychiatry, listen to this career. After a residency in psychiatry, Renee joined the Air Force, where he graduated in aerospace medicine and took up a military research position, from which he retired with the rank of general. Renee has been involved in several major European research programs on human error and risk management. He pioneered the concept of pilot's assistant, ecological safety, and crew resource management. He was the first head of human factors and flight safety of the Joint Aviation Authorities. In the 1990s, Renee progressively diversified his research fields, studying risk management in the nuclear and oil industry, professional fishing, and public ground transportation. In the 90s, Renee undertook research in the medical field on medical errors, patient safety, system approach, and resilience. He has published more than 100 international papers, chapters, and authored or co-authored 10 books. Renee has been chairing the ISQua Innovation and Systems Change Working Group since 2013, which is focused on identifying solutions and sharing best practices in the field of aging populations. This subgroup of the board has published a white paper and article in the International Journal for Quality in Healthcare. More articles are soon to be released. The group has facilitated a number of workshops at ISQua conferences focused on the need to adapt quality and safety standards to meet the global issues of aging populations. And he's also been an ISQua board member. In recognition of his contributions and commitment as a board member and chair of the Innovation and Systems Change Working Group, I am delighted to award the Distinguished Service Award to Renee for his research and contributions to the areas of medical errors, patient safety, system approach, and resilience. Congratulations, Renee. Speech.
I'm just delighted.
He's delighted.
Congratulations. Thank you.
So good afternoon, everybody, and it's a real pleasure and honor to have this opportunity alongside my colleagues to be talking a little bit about Alma Ata at 40, quality and primary healthcare challenges, opportunities, and urgency. So in the next 60 minutes, we're going to take a little journey through time. And I think there are, of course, many of you within the audience that know more about the subject than I do. But back in 1978, a huge moment in global public health and certainly in primary healthcare that really galvanized attention on primary healthcare and took us to another level in that subject. Now, the critique, of course, was that there was a huge momentum, a commitment, but what did that lead to in the real world and in the real services that we work in? So 40 years have now gone by, and in a few weeks' time, global leaders will be reconvening in Kazakhstan, but this time in Astana, to figure out what has happened and to reinvigorate the journey related to primary healthcare. Let's take a quick step through what has happened. So PHC over time. In 1978, the declaration was made, health for all and human rights, really at the center of this. Local care, close to home, healthy communities, all of those things that I think many of you are very, very familiar with, and the first level of contact for individuals and their families. Moving on, 2008, because it's not, the decades have passed, but there's so many things that have happened between 1978 and now, but just taking a skip into 2008, the Tallinn Charter for Health and Development, of course the Millennium Development Goals, and further charters on primary healthcare across the world, but importantly also at the regional level. So at that point, of course, the increasing focus on co-production of services, really focusing in on patient records, defining population catchment areas where services are provided, primary care networks evolving. Around that time, huge reforms taking place in many, many countries, and PHC becoming a core coordinator. 2018, where are we now? So integrated health service delivery, big push on that through the work that all member states have endorsed in terms of the integrated people-centered health services framework. Now that's a long phrase, but it means integration, PHC together. Of course, the Sustainable Development Goals and universal health coverage. Where are we with all of the key elements within that? Of course, the new technologies, the medicines, the patient preferences, the choices, patient engagement, all of that needs to come into that thinking, and it is doing so. So many of you have already heard this in different sessions during the last day or two, but it is important that the affirmation of quality as central to UHC has been firmly made this year. I highlight the WHO, World Bank, OECD report on delivering quality health services as a global imperative for UHC. But as you all are aware, two further publications, one from the US National Academies of Science and one from the Lancet Global Health Commission, the Lancet Global Health Commission on high quality health systems, all three emphasizing quality as firmly embedded within universal health coverage. Very simply put, but on the launch of the final set of the final publication from those three, my boss, Dr. Tedros, said it very unequivocally that without quality, UHC remains an empty promise. Very simple statement, and as you, and some of you have heard me mention this previously, but Dr. Margaret Chan, early days, had highlighted very clearly that what good does it do to offer free maternal care when the quality of that care is substandard or even dangerous. And this was predating the Sustainable Development Goals. So when we look at this and we think about the components of PHC, and this is advanced because this will be released during the Astana conference. But let's just take 3 points and just move and just think a little bit about what each of those points mean, because these are the 3 pivot points around which the PHC movement will move. So the first one, and importantly, is this multi-sectoral policy in action. Really important point from a primary healthcare perspective. Here, empowered people and communities, again, central to primary healthcare traditionally and as we move forward. And finally, integrated health services, prioritizing public health functions and primary care. So notice the difference between primary care and primary health care. But the important point, and an important point for sure, is here we are talking about public health approaches. So really emphasizing public health approaches to services at the same time as delivering services of a high enough quality that populations deserve. Now, one point to emphasize there, when we're talking about services, we are not just talking about curative services. We're going all the way from health promotion to prevention, to the treatment, to palliation, and rehabilitation, and to palliation. So the whole stream. And I don't think I'll need to convince you, but PHC, of course, primary healthcare, is uniquely well-positioned to be able to respond to a complex and rapidly changing world. We don't have time to go into the detail because we will be listening to three very important perspectives. It's proven to be a highly effective and efficient way to address the main causes and risks of poor health. And importantly, it will not be possible to achieve the health-related SDGs or UHC without stronger primary healthcare. Final slide, but this is an important one. Just have a look. So these are the three pillars. But here, and this is what we've emphasized throughout the discussions in the last day or two, is safe, effective, people-centered as core domains of quality, with an emphasis also on equity, efficiency, timeliness, and integration. This is essentially from that WHO, World Bank, OECD report. But you can see on this side, high-performing primary healthcare is people's first contact, comprehensive, coordinated, people-centered, continuous, and accessible. So when people are talking about that primary healthcare, this complementarity between the domains is very strongly evident. This is going to be a really important arena for us to be able to merge and blend and integrate with the PHC movement. And when we're talking about quality, if we don't take that into consideration, we are not going to make the impact on populations that we all want to see. There will be a background technical document that's just in advanced draft stage for the Astana conference related to quality in primary healthcare. And of course, we will be making sure that ISQua colleagues have all of that to hand. So, coming to today, when it comes to quality in primary healthcare, and I'm going to encourage you all to, the tweeters amongst you, please share your thoughts, and as the speakers move forward with their discussions, if you've got any perspectives, share it. What are the key challenges? What are the windows of opportunity? And what are the urgent actions required? We have three wonderful perspectives, and the first one we're going to go to is Mexico. For us, we recognize that with the work in Mexico, it's a decade-long experience on quality, but we have the privilege and pleasure of welcoming Odette Sarabia, who has nearly 2 decades of experience at the Ministry of Health in Mexico. She gave life to the first patient safety initiatives in Mexico. She led the Ibero-American Study of Adverse Events in Mexico, and she is currently the Deputy Director General of Quality in Health at the Ministry of Health. She's a physician by training, and her postgraduate work is focused on health systems management. Just in case she didn't have enough to do, she's also Vice President of the Mexican Society of Quality in Healthcare. So with that, if I can welcome Odette.
Well, first of all, I want to thank Dr. Syed and the organizers of ISQua for their kind invitations to be here this afternoon in this beautiful country, in this beautiful city. In the next few minutes, I will briefly explain the context of the Mexican health system and try to answer the 3 questions that Shams has put into discussion. Mexico has a fragmented health system. People can access the system with or without social security in several ways. Those who do not have social security through popular insurance or Seguro Popular, if someone of you know this one. And the ones that have social security by IMSS, ISTE, or PEMEX, or other institutions that has their own health system. This is associated with the level of income of the population, and funding varies from one sector to another sector. So the services provided by health centers, hospitals, or national health institutes, in the case of Seguro Popular or national health insurance, or by the ones that have social security. They are provided by family medicine units, general hospital, or specialized hospitals. And those who has the money to afford private sector, well, it works more similar than other countries. So here I want to show the epidemiological transition, the mortality from large diseases groups from 1980 to 2015. So you can see how cardiovascular diseases has been increased, the same as malignant tumors and diabetes mellitus. So we have a huge problem in Mexico with obesity. So this is the context and the epidemiological context. And the demographic pressure, we have a huge demand on health services. Here you can see through the years what we are expecting, all the Mexicans that will be over 60 years in the next few years, and this is a huge pressure for the system. So we need to focus on strategies around healing healthy aging. So what we want to do is to pass from a fragmented system to an integrated system where we can standardize under a single government policy that evolves into a unique health system with universal healthcare grounded in a quality primary healthcare. We also need that this unified health system performs the essential functions in public health under a scheme of primary healthcare. For that, we need the co-responsible population to have a healthy life, the population commitment to their health, their family, and their community, and the commitment of other institutions that are focused on social security, such as the Ministry of Labor, Finance, Education, and other, to promote the healthy social practices. So this way we can decrease the health inequities. Here is an example of the disparity that we have in Mexico. Here you can see it's not the same to be in Yucatan, one of the states in Mexico, than be in Baja California Sur here. So if you go to Yucatan and have a stroke, AMI, you have 55% of chance to die 30 days after the admission to a hospital, but if you are in Baja, you have 10%. So this is a huge gap between one state to another state. So these are the inequities, and if we don't work harder on patient safety and quality, these are the results that we have, this heterogeneity in our country. So what are the windows of opportunity? Well, a new government is going to start in Mexico next December, so they will have majority in the Congress, so we will have the power to make the necessary reforms to transform the system towards its integration. At this moment, we have some progress with the exchange of services between the different institutions, the health institutions in Mexico, that allows to optimize the infrastructure. One example is the obstetric emergency program. If a woman has any obstetric emergency, she can go to any one of the microsystem that I already told to you, and she needs to have the attention, and she will get it. We also have this global trend towards the strengthening of primary healthcare with the referral of Alma-Ata at Astana next October, and we are implementing the quality management model. The quality management model in Mexico is focused on primary healthcare, and it's focused on center person focus, and we are focusing in 5 value results. One is the population health, the other one is effective access, the third one is to construct organizations that are reliable and safe, and the fourth reasonable value result is the satisfactory experience, and finally, reasonable costs. So what are the urgent actions? The first one is the political will to achieve a quality primary care, to create a sense of urgency in our people, families, and community to take care of their own health, to create a universal catalog of services to all the institutions of healthcare in Mexico, to have a unique medicine catalog, to increase the investment in health, and to keep implementing the quality management model at the micro, meso, and microsystem. So what do we want to achieve? We want to achieve a unique health system with universal healthcare grounded in quality primary healthcare, and as Shams already said, with a quality care services and with high-performing primary healthcare. So, thank you.
Thank you very much, Odette. We're going to now switch continents and come to the African region, and my dear friend and colleague, Andrew Lukaka, who many of you know. He's the Director of Quality Management Department at the Ministry of Health in Malawi. He's a medical doctor by background with postgraduate focus in public health. He led the architecture development of the Quality Management Directorate. So we're hearing a perspective from a very well-established directorate in Mexico to a newly evolving one in Malawi. Just in case he's not got enough to do, he's just been appointed to head the newly established e-health division in the Ministry of Health as well, and is also the chair of the National Quality Commission for Health Systems in Malawi. Andrew.
Thank you very much, Shams, and good afternoon. Oh, good afternoon or evening. All right. I thought we were sleeping, so I will try to make sure that we are attentive. So Amata at 40, we are celebrating 40 years of Amata. Quality and primary health care, challenges, opportunities, and agency. Let me briefly talk about Malawi. Malawi is a country located in southern part of Africa, 2 hours flight from Johannesburg, 4 hours flight from Cape Town, where we'll be next year. It's a country with a population of 17 million, and the health system is a 3-tier, primary, secondary, and tertiary. We've just finalized and developed a national quality policy for the health sector. Now, when it comes to key challenges for quality and primary health care, there are a number of interesting things that have been specific to my country, but I'm sure also to most of the developing countries. One of the key areas that has been challenging is the local definition of quality. During the entire 40 years of Amata, quality was defined based on the definition that is in the book, but not definition that can be stipulated from the local communities. Community voices have been also missing in demanding quality of care at primary level. Capacity building for health workers mostly focused on disease rather than a person. So experiences are that now patients are no longer being identified by names, but they are identified by disease. So you hear a 45-year-old lady, sorry, a 45-year-old cervical cancer patient, a 10-year-old a Down syndrome boy or a Down syndrome girl, but this girl has got a name. So health workers stopped already identifying a person, but they're identifying a disease. Health system challenges have been great also, looking at challenges in human resources for health, leadership, weak leadership and governance, as well as availability of health support services like laboratory services, medical equipment, and these have been key challenges. Lack of accountability to poor quality. Who pays for poor quality? The cost of poor quality hasn't been yet estimated to date. Countries are always thinking that it's expensive to invest in high quality, but it's more expensive to invest in poor quality. Unfortunately, that statistics is not coming out. Political will has been tailored mostly to improving access than quality. You agree with me that we had the Millennium Development Goals. We've been talking about health for all. Now we have universal health coverage. Quality has been silent for the past 40 years. Nations were focusing mostly, in the case of Malawi, we've been focusing on immunization coverage, but not the quality of the immunization. Just a few years ago, we were hit by measles, yet the coverage for measles was above 85%. And it was not only in Malawi, even the US had the same problem. So we've been focusing on access, forgetting about quality of the services. Primary health care also was focusing more on getting data from population instead of providing what matters to that population. So populations don't mind how many people have died, how many people are suffering. All they need is they have what matters to them that need to be addressed. But for us as health workers, focus has been how do we collect data from these populations. Huge talk on integration, but there's been little action. 40 years after Ama-Ata, despite the talk on integration, integrated health systems, we still have vertical systems. And curative services are not talking to preventive services or community services. Finally, most of the quality care interventions at primary health care have been implemented as projects or pilots. They've not gone beyond maturity or scalability. We are still piloting. What are the opportunities that we can get in this momentum? Universal health coverage provides the only hope and opportunity that we can utilize, because there is a lot of talk on quality as well as financial risk protection. National quality policy and strategy, WHO has just come up with an initiative, and documents have been released to guide the countries on making sure that they are coordinated and they are able to have documents that can guide direction to push quality. Role of non-state actors to empower communities to demand quality of care. We've seen CSOs, civil society organizations, taking a lead in this area. Not forgetting technology, it's another opportunity. In rural areas, in every community, at least majority of the people have got a cell phone, and we can use those to inform progress. For Malawi, there have been strategic objectives that have been highlighted when it comes to quality, and really from leadership up to use of data. Now, what other opportunities exist? Role of media. Media is another third arm of government. They are ready to expose elements of poor quality. It should be taken as a positive. Health institutions are now realizing that the quality of care is different from quality of medical education. what we expect as health workers is different from what the training institutions are normally accredited upon. The newly released Lancet Commission report has highlighted basic bottlenecks to improve quality. This is another opportunity that is lying with us. In Malawi, we are moving forward with service charters to make sure that health workers, providers are accountable to the community, and the community is aware of what is expected on their side. Finally, what are agent actions? Countries should adopt national quality policy and a strategy. Without a policy, we cannot coordinate the mess. Country leadership and ownership of the quality agenda should be key in primary health care. Let's hear more voices of countries, local ownership than donors. Local communities should provide a clear definition of quality. What matters to populations or local communities will matter as we move with the quality agenda. Service integration and drive for continuum of care need to be enhanced. Personal-centered care should drive all interventions. All our interventions should be centered upon a patient. Finally, let's stop all pilots. Let's stop all projects. Let's evaluate what has worked over the past 40 years and what hasn't. And let's scale up best practices. Thank you.
Thank you, Andrew. Our third perspective comes from Cliff Hughes, who needs really no introduction, immediate past president of ISQua, surgeon by training, and I'd like to say a heart-based practitioner by inner calling. Passionate advocate of PHC as part of Quality Health Systems. Cliff.
Thanks, Sam. It's getting late in the afternoon. I've been asked to give a broader view of what all this means. So I actually went back and read the Declaration of Alma Mater. Okay, 40 years almost. Long way from the countries we've been talking about. It's in Kazakhstan. And I thought, what can we learn from the past? And I thought we should actually have a look at the broader view of what all this means. And ask a question, a different question. Does the global village in which we all live make it easier or harder for us to see the future of well-being and for our patients, those that we serve, to experience the feeling of well-being? You see, it is a battle. Healthcare is a battle and always will be. But sometimes we get things wrong. We need a vision. Unfortunately, sometimes, if we have a close look here, whoops, I'll go back, we can actually see that the lens cap is still on. And high technology can blind us to the pain of the battle of healthcare. But on the very same photograph, we can see that there's a soldier wearing glasses. I spent some time in the Army Reserve. I didn't see active service, but I did a lot of work on the health of soldiers. And there was a time when wearing glasses meant you couldn't go to the front line. But we know that's now nonsense. If you need glasses and you wear glasses, you can go to the front line. So we do need to have a vision, and we make sure that technology doesn't blind us to that vision. Because sometimes we look too closely instead of having a look at a broader view. Sometimes we assume the politicians are going to get it right and make it easy for us. That's a dream that's not likely to be realised, because all they talk about is money, the politics of the economy. So I thought we should have another look around, and let's have a look at the Crimea for a while. Florence Nightingale, a lot older than 40 years into history, she tackled the conventional wisdom of the day and introduced a new order. Now, you might say, but hang on, that was in a military hospital. That's not primary care. I'm sorry. If you've just had your leg severely injured and you're facing an amputation because of gangrene, that's primary care. That's right at the heart of the battle. And conditions were not things that we could control. And we need to understand that primary care, like healthcare anywhere else, is difficult to control. So what were the tools of trade that Florence Nightingale used? Very simply, she collected the numbers. She just started counting. Counting what patients had when they came in, what treatment they had, and how well they went after the treatment. And she found out that there were more people dying of failure of hygiene than were dying of the primary injuries on the battlefield. So she taught her nurses to wash their hands and to teach other people to wash their hands. And she showed them how to do it. She began a QI program based on numbers. And then she wrote it up. If you want to read a really, really basic, fundamental textbook of what to do right in QI, read Notes on Nursing by Florence Nightingale. It's a textbook for the ages. And that's the simple tools that Florence Nightingale used to change primary care where she was. We can do the same. But what was the greatest challenge? I'd suggested to you it was the military hierarchy within which she was working. And sometimes we actually find ourselves working in the very organisation that becomes our greatest challenge to block what we want to do. In Australia, we have a unique problem when it comes to primary health care, because the federal government looks after primary health care, the payments of primary health care. The state governments essentially look after the payments for acute care hospitals. And aged care is funded by the federal government. So we actually have a bureaucratic structure that says, move people out of our environment, somebody else can pay for their care, we don't have to worry. And no one gets treated properly unless we actually start to change the order. But Florence Nightingale wasn't put off by that challenge, because who were her greatest allies? They were the people who read the numbers. They were the commanders who realised that their troops weren't going back to fight because they were dead. That there were people who could actually have their legs saved. And she used the very same people who'd made it hard for her to become her allies and drive change to change the established order. The Declaration of Alma Ata also has changed, in my view, the established order. Just have a look here. I'm not going to go through this in detail. On the left, there's the established order of the clinician-patient relationship. It's personal, private, isolated, under-resourced, minimal corporate structure, particularly in primary care. Where is accountability? Where is accountability? Where are the process audits? Where are the outcome audits? Where's the peer review that Florence Nightingale wrote about years ago and sent her notes on nursing to hospitals around the world? The Declaration talks about well-being, not about sickness. It talks about unacceptable inequality, stuff that we must do something about. It talks about social determinants, and we have to look beyond ourselves to make the environment work for the benefit of our patients. It talks about world peace, something we should strive for. A long way from that, aren't we? But it says people have the right and duty to participate individually and collectively in their own care. That's not patient-centred care, that's patient-based care, where they're the basis of everything we do, think and say. And then we address the main health problems. What are the main health problems? They're the ones that our patients tell us about. We don't understand why we've got to do these things. There's no education. We can't understand why we get sick after a flood because there's no safe water. We understand that sanitation, immunisation, etc., etc., etc. are the main health problems. The people in our villages, in our cities, in our towns, and our public transport systems understand the problems. So the new order with Nightingale was nurse-led hygiene, not surgeon-led amputations. It was well-being, not interventions. It dealt, pardon me, it dealt with spread and sustainability such that the army took over. Compare that with the work of Semmelweis and puerperal fever. It was the doctors that actually blocked any improvement. It was the doctors that said Semmelweis was mad. It was the doctors that put him into an insane asylum. It was the nurses, the midwives who recognised he was right. Alma Ata is multi-sectorial. It promotes maximal self-reliance and gets our healthcare contextualised to where it is being delivered. It actually improves and expands community self-reliance. And it says we must have appropriate referral systems. I am not the arbiter of everything for my patient, but I have to find out who's the arbiter of what my patient needs for that problem right now. And it relies on traditional and non-traditional workforces. What a turnaround. You mean it's not just the doctors and nurses? No. I borrowed a slide from John Brennan in his presentation yesterday. This slide basically says who have the most innovative minds. Okay, 5-year-olds, 98% are innovative. 10-year-olds, 30%, 15-year-old, 12%. You and I, 2%. And I'm probably on the 0.5%. We need to look where we can make the change, and we can make it with a new, emerging, young workforce that is dedicated to the principles espoused in the Alma Ata Declaration, which is almost 40-year-old. Because that new order really comes to the heart of the matter, and it challenges our values. This is a logo that I had drawn up when I was working in an inner-city ministry program in Woolloomooloo in Sydney. We were serving an indigent population, a lot of drug use, a lot of sex work was one of the biggest industries, a lot of homelessness, alcoholism, the whole lot. I asked a friend of mine who was not part of this program, he was the director of an advertising agency, to come up with a logo. I said to him, we have to change the community. And he said, well, you're a heart surgeon, why don't we play on the heart? Why don't we make the words rebuilding the community beginning with the heart? I said, that sounds okay, Peter, go for it. So he sat down with all his young advertising executives to come up with a logo, and this is what they came up with. And I looked at it and said, it looks pretty, but tell me about it. He said, well, actually, we need a new greenfield site. Let's get rid of all the old ideas that bind the way we look after people in the inner city. Let's freshen our view, a greenfield site. And let's change the heart. And I said, well, that looks pretty good. He said, there's a problem. And here's the problem. And he had some cardboard cutouts of each of these coloured bits here. He said, Cliff, can you make a whole heart of the same colour out of that logo? And you can't. It's physically impossible. They're all the wrong shape, or there's bits missing, or there's something that's too big or too small. He said, you see, our young people said, we actually have to change the notion of the romantic heart, the feel-good heart, to something that actually works. And that is called compassionate, loving care. That's what the Alma Ata Declaration is all about as well. A few technical details thrown in. But if we want to drive change, we have to be the change we want to see in the world. Gandhi said that. Gandhi was right.
Thank you very much, Cliff. So we've heard 3 really great perspectives. So I think let's hear from you guys for just a couple of key points that emerge from each of the perspectives. From Odette in Mexico, quality management model focused on primary healthcare with a clear emphasis on the equity agenda. Malawi, highlighting needs for quality to be embedded within the understanding in local communities for primary healthcare, and the importance of thinking to scale from design. And Cliff beautifully explained that primary healthcare needs to think about hospitals, going back to history. So this is where the whole integration piece comes in, the power of numbers, but the power of values, really important. So I would love for colleagues to share their perspectives. Please, this is an opportunity. We've had a moment so that you can share your thoughts. Who's going to start us off? Do I see a hand in the back there? Am I hallucinating? There you go. Fantastic.
Hello, everyone. I'm Dr. Mubashir Angolkar from India. I head the School of Public Health, and so Alma-Ata is very close to my heart. Maybe that's why that's the only hand that went up. So I'm sorry, I don't remember the names, but professor who went in the end, I loved when you said that you actually went and read Alma-Ata again, because I know you knew it. And then there was a publication in 2005 revisiting Alma-Ata when we had 30 years. This seems to me like a school debate I had ever since. You know, when I was in school, we debated on euthanasia, and we debate on that today too. Alma-Ata seems to be the same topic. You can just go on talking about it for 40 years, repeat the same thing, and we are where we are, where we started. Maybe with a little improvement here and there, but we are where we were. I think you quoted Gandhi in the end, and earlier today I heard in one of the sessions someone quoted Einstein saying, you cannot find solutions from the very thinking that created it. You know, I don't remember the exact phrase, but it said that the minds who created the problem cannot find solutions to it. And that's where your slide where you showed 5%, 2% innovation, you know, we need to look at the new generation, the younger, to come out, think out of the box, come out with different ideas, do things differently. Nightingale, Florence Nightingale at that time did things differently. Archie Cochrane had just a handful of medicine, and he gave everybody, which came up with a placebo effect. So, you know, we need to think differently and do things. Here, I think, I don't know why we talk about quality like this. Isn't it something like a birthright? Isn't it like how somebody today in one of the quality assurance was saying, speak softly and with compassion to your patients? Really, do you need to teach it? I thought this was taught to me in nursery, to be soft, to be honest, to be kind, to be compassionate. And here to adults, we are teaching the same thing that we teach our kindergarten children.
Thank you. Thanks for that perspective. Anybody else would like to share any thoughts? Before we, please, sir.
Hello, my name is Camilo Gutierrez. I am from Bogota, Colombia. This is a question for Dr. Saravia. One of our issues when dealing with communities is that they don't feel they are receiving the same quality of healthcare when seen by primary care specialists. They feel it is somehow they don't see the same value in it. What strategies can we use to make sure our communities take charge of their healthcare? How can they see the value in primary healthcare? Thank you.
Thank you very much. Let's take another one, please, madam.
Actually, he almost took the words right out of my mouth. Because in the country that I live in right now, as much as they're trying to bring in primary health care, again, it's the same concept. The people don't want to go to primary health care. They don't think they're getting the same level of care. And they still feel that if they've got the money to pay for it, they will go into the private, where unfortunately they don't realize that they actually go into the wrong part. And I think, too, even within the primary health care, the physicians that are there, although in some cases the patients are forced to see these physicians, the physicians refer them on to specialists rather than handling the issue in the primary environment because they succumb to the pressures of the patient to say, well, I need to see ENT, I have a sore throat, I need to see ENT, and so they'll refer them on. How do we change that concept?
Thank you so much. Before coming to each of the panelists, if I can take one more, please, sir.
Yeah, thank you, sir. So all the three speakers really addressed the issue of primary healthcare. I'm Dr. Rajesh Saini from India. And I liked the presentation from the Malawi, what sir said, that we have done enough of pilots in primary healthcare. So when we say pilots of primary healthcare, we know the challenges also. We know there are challenges in infrastructure. We know that there are challenges in human resources. And we should go to the basics, actually, seeing what should the primary healthcare actually should be giving to the people. Promotive, preventive, curative, and rehabilitation. So promotive and preventive and part of the curative, what we have to deliver at primary healthcare, we should see that. So the limitations, challenges, we already know. We have already seen the models, pilots, enough of that. So let us accept this and come up, WHO should come up with the model, uniform model with quality embedded into it. That's it.
Thank you, sir. One final one, please.
Thank you. My name is April Prabowo. I'm from Indonesia. Thank you for the amazing presentations and enlightenment for all of us. The questions that I had regarding with the current context in my country, we currently embarking in the new journey of expanding our primary healthcare quality, as well as advancing our the access to healthcare through universal health coverage. But one of the main issues are the divisions of with some of the practitioners who don't agree with the improvement of training systems for primary healthcare doctors, and those who are agree. And these two camps comprises of both people who are currently working at the primary care level and then secondary and tertiary care level. So my questions will be, please give some guidance, particularly if it's my needs as a young doctors to engage and collaborate with those who are currently, in the different stance, right. And to bring this promise of primary health care. And because it will be useless to talk primary health care if we are disagree on the visions that we want to share, and like a lot of method or strategies that we need to work on together and collaborate. So that's the main questions. And as a closing, I'm a family medicine and global health practitioners, and I'm currently quite confused on how to tackling on the issues in my country. So okay. Thank you very much.
Thank you very much. Let's turn to each of our panelists. Odette, would you like to start us off?
Well, thank you for all the questions. The first one of the Colombian guy, the thing is, in Mexico, what we have been doing is to strengthen the GPs, and we have done some work with algorithms based on clinical guidelines. The clinical guidelines will develop with the most recognized physicians, specialists in Mexico, and we make these algorithms through the clinical guidelines. And the challenge were that this must be applied to all the institutions that has this different kind of healthcare in Mexico. So we accomplished this, and we developed them with all the drugs that are in all the healthcare system. So this way they can have the experience of the most specialized in Mexico with these algorithms, and now we are strengthening the primary care the first level of attention. So this is how we are working now. I guess the thing in countries like Mexico, maybe Colombia, I don't know the others, the thing is that sometimes the primary health care, the first level of attention is not as strong as the specialized medicine. So everyone wants to make a specialized medicine because it's not resolutive in the primary healthcare. So what we need to do is to strengthen the primary care, to strengthen the way that physicians in primary care can give and be more resolutive at the primary care. So I guess that's what we need to work
Thank you, Odette. Andrew, would you like to pick some of the perspectives and provide yours, please?
Thank you. I think the comments and questions have been also enlightening to me. Parotitis is a disease which quality improvement teams may be facing. So parotitis, this attitude of piloting without scaling up. Eventually, I just hope that it will be another decade of action. To agree with a colleague in India, by now we must know what works and what doesn't work. Countries need to be on the leadership. The problem is that even if the quality agenda is driven by partners, donors, and the donors have different interests. The reason WHO came out with guidance on national quality policies and strategies to try to provide the leadership and governance that is required so that there is direction. So I think the key lies in all of us pushing our governments to take leadership. And everyone is a leader at any position, at any locality. Once we take leadership, we spearhead on what works. I think the next decade, the next 40 years will be different. Otherwise, I agree that it looks like we are moving back to the same place. Now, why primary health care, some people tend to shun from them. There are 5 whys we need to be asking in every scenario. Why is it that primary health care maybe is not regarded by communities or it's regarded better by others? How are we designing primary health care? Are they responsive to the needs of the people? And sometimes we tend to forget that patients, we think that we are designing programs for patients who are outside our rooms, but we are the patients ourselves. We must change the way we design things. We need to start thinking about ourselves. We need to be selfish when thinking about quality. Quality is about us, about me. What is best for me is best for them. So normally, when we are designing primary health care services, we don't think that we ourselves are living in the community. We think it's the community for others, not for ourselves. So maybe it has to start from us. What would be best primary health care for me? Thank you.
Thank you, Andrew. Cliff.
Thank you. I don't know if you can just show the last slide in my presentation deck, please, if it's possible. While you're looking for that, I want to talk about the issue about primary care being seen to be a secondary citizen. I think part of the problem is we've missed the opportunity to sell the value of primary health care appropriately applied. The slide is basically of a small latrine that was built on the subcontinent, built by a village, a very small village, about 10 kilometres from the hospital where I was working. We had a 50-bed hospital. We were going on a picnic and we came past the village and I saw this latrine with 2 screens around the hole and it looked fantastic. But I said to the person, the leader in the village, but it's in the wrong spot. It's actually above the water supply. You've built it on a hill, and the well is only about 50 metres further down the hill. The bad things go from the latrine to the water. That's why your children are sick. And we went off and had our picnic. When we came back in the afternoon, he had moved the latrine. And the slide I have is of it below the village. The public health doctor who'd been working in that hospital for about 2 years was very angry. He said, "Why didn't they listen to me? I've been trying to say that." The nurse who ran the hospital single-handedly, apart from this doctor, said, "But the thing is, we didn't show them the benefits. They didn't know." Cliff came here, he did some surgery, and they saw people get better, so they assumed he knew everything. Well, I know I don't know everything. But they responded to the data. And we don't tell our patients the data. We don't tell them the truth. We don't tell them the good news. We can do it, but as the songwriter said, don't talk about love, show me. And that's the theme of this meeting, is it not? It takes heads to accumulate and measure and talk about the data, hearts to show that we actually care, and then hands to rebuild our systems.
Thank you, Cliff. Unfortunately, time is tight. We will continue to explore this throughout the next couple of days. We've had a very, very good discussion today, and just a couple of reflections. Is it okay to debate? It is, because if we don't debate, then we can't act. So has the debate enhanced population health across the world? I believe so. Has it affected population health enough? The answer is no. If the quality world doesn't link up with the movement on primary health care, quality world is going to get left behind. And that's a clearly stated point, and it's a little provocative, but it's important to emphasize. With the universal health coverage work and the redesign of health systems across the world, we know that systems are going to be redesigned, and this is the opportunity to embed quality within that system redesign. So that is going to lead to essential packages of health services across the world, particularly in low-income countries, and we shouldn't forget the fragile settings that we're working in, where primary healthcare perhaps is even more important, and quality has to be right at the heart of that work. The final point, and this is really picking up on all of the three speakers, is that compassion has to be at the heart of that. And with that, I really do applaud ISQua for highlighting the role of the heart in the work on quality, and it is very clearly linked with the primary healthcare movement. Thanks for all your thoughts, and thanks very much for the wonderful panelists. Thank you.